let's get in the mood, learn some pathology. I know you guys have radiology, and we're going to try to kind of shift our focus a little bit. So we got this person here, 54-year-old female. She's coming in. She's got ovarian cancer. She has some chemo. Yesterday she developed this issue in her legs. There's no recent travel, no injury. What is she at risk for developing? Justin? D? D? Alright, so PD, right? So we talked about how, she's got cancer. That's a risk factor for developing these blood clots kind of out of nowhere. There was no, other potential causes of this based off the vignette. And so you're supposed to see that leg, right? Think about EVT, and then if that blood clot breaks off and it goes to the lungs, then we're concerned about a PD. Why would she not have a blue toe infarction? Right. Yeah. So this is a venous issue, right? So that blood clot starts in the veins of the leg and then goes to the heart and the lungs, and then if it was a arterial issue, then it would go either to the brain, right? Other places like the kidneys, or potentially that toe. Alright, so we got this patient, they got AFib, it's chronic, atrial clot, it obstructs their cerebral blood flow. The brain tissue past the emboli will experience what condition? Ischemia, right? So if we block that blood flow, we're going to slow it down, we're going to cause that ischemia, and then eventually, if we don't open up that vessel, it's going to lead to infarction. All right, a little bit of a longer one, I'll let you guys read that. I'm hearing some stuff out there. Yeah. I like that, right? So she's got this GI bug, this virus, it's causing vomiting, diarrhea, she's losing all this fluid. She's starting to show those signs of shock, right? She's confused, she's not thinking clearly, she's got a fast heart rate, low blood pressure. So do you guys think this is compensated or decompensated? Decompensated, right? She's got some features of compensated because she's got that tachycardia, but she's starting to kind of move down that decompensated pathway. And if she continues on that pathway, then it's going to be uncompensated. So if I was to ask you something on this, and again, I don't know if I will, because I haven't got there yet, but I will. If I was to ask you something on this, I would make it, there wouldn't be two correct answers, right? But based off this scenario, she's most likely experiencing hypovolemia because she's losing all these fluids. Cool. Alright, so this is the last lecture, right? And you guys, we'll meet again Friday. I'll be proctoring your farm exam, I think. I'm pretty sure I am. Then after that, we'll do a review. And the review's optional. I know you guys have stuff after the fact, but that review, if you got better stuff to do, please take your time, do what you got to do. But there will be a review at 10 o'clock after the pharmacy test. But today, we're going to be talking about the hematopoietic system, so kind of our blood forming system, and then our lymphoid system, kind of focusing on anemia. We're going to talk about different causes of anemia. We're going to get into something called polycythemia, which is just an increased amount of red blood cells, or it could be white blood cells and platelets as well. We'll get into a little bit of leukopenia and leukocytosis. We're not going to get too far in there. And then we're going to talk about lymphoma, we're going to talk about myeloma, multiple myeloma. And I've talked about that briefly in the past, kind of brought it up about those types of cancers that can cause issues in our lymph nodes. And then we'll finish it up with platelet disorders and talk about what you may see if we have some type of issues with our platelets or our clotting system. All right, so just to review, I know you guys, again, haven't had lab yet. She's going to get into all this with you. But our blood cells, they start from one type of stem cell, right? And they can split off. And when they split off, they can either form our granulocytes, our platelets, or our red blood cells, right? Where they can split off and start causing or forming our lymphoid tissue, or lymph nodes, or not lymph nodes, but our lymphocytes. And so, based off that, it's going to determine, especially when we get into the cancers, what you might see. So, red blood cells. So, the erythrocyte, the red blood cell, its main job, as you guys are aware, is that it's supposed to transport oxygen to our tissue. We need red blood cells to do that job. That's their sole job. And if you've ever seen a red blood cell, right? If you've ever seen a picture of it under a microscope or whatnot, it doesn't have a nucleus, it doesn't have organelles, and we don't want it to because we want all that space to be full of hemoglobin. We want to use that space to our benefit. And if we had a nucleus, if we had organelles in there, well then we wouldn't have enough space for hemoglobin. Now when it's starting to form, it does have a nucleus, and then as it starts to mature, it's going to lose the nucleus. But because it doesn't have those components, doesn't have those organelles, the problem with these red blood cells is that they don't last too long. They don't have the material that it needs to help kind of regenerate itself. And so after about 3 months, that red blood cell is going to die. Now thankfully, our bone marrow is able to make new red blood cells, and we need that because we're losing these red cells eventually. When we lose them, we need to replace them, right? The red blood cell, it has a characteristic shape, right? It has this bioconcave shape. And it's important that it has that shape because it does a couple of things. It increases the surface area, so the greater the surface area, the more it's going to be able to interact with our tissue, release that oxygen, take up that carbon dioxide, and then get it out of the body. But also, too, because it has that shape, it's very flexible. And if you think about the capillaries, if you think about our small vessels, they only have enough room for one cell to go through, right? And if we didn't have that flexibility, well, then when that RBC is trying to move through that capillary, it might get stuck, might get caught, and if it gets caught, it might break. So we want that RBC to be flexible because if not, then we can potentially cause issues with damaging that thing, and it's going to die a lot sooner. You guys know that it has hemoglobin in it. Now hemoglobin, it's made up of 4 heme groups and 4 globulin groups. So 4 proteins and then a heme group. The proteins, they're what kind of determine what type of hemoglobin we have. So normally we have hemoglobin A. That's the normal hemoglobin that we're supposed to have as an adult. We do make something called A2, and we have a little bit of that, and that's normal too. And it's still able to transport oxygen to our tissues, but our body prefers hemoglobin A. So we have A, we got A2, that's normal. We don't typically have hemoglobin F. We don't typically have it. If we do, maybe it's a very, very small amount, but typically we don't have it. Hemoglobin F, that's more for the fetus as it's developing. Hemoglobin F has a higher affinity for oxygen. So we want that higher affinity for oxygen because when that mom's blood is going towards that placenta, kind of passing the placenta, and then the baby's blood is passing near the mom's blood, that higher affinity is going to take that oxygen from the mom's blood to the baby to actually help the baby get the oxygen that it needs, right? It's not breathing in the womb, so it needs to get oxygen somehow. And that hemoglobin F is what helps pull that oxygen to the baby, that way it actually has oxygen. The heme, right? So the heme is a component that's inside of the globin, and it has the iron. And it's the iron, it's that whole thing, but the iron that the oxygen actually is able to hold on to and then goes to the body and get expressed to our tissues. So we need those components. Now I'm going to throw out some lab stuff here just to kind of plant the seed, but again, lab's going to go into a lot of detail about all the labs, and there's a ton of them out there. But for the blood, there are a few labs that we care about. So hematocrit. Hematocrit, all that means is that we are comparing the percentage of red blood cells to our total blood volume, right? So we want to know, give or take, how many red blood cells do we have per plasma? Normally, we should have about 40 to 55%. Now, I'm going to tell you, when you get to different labs, when you're out there working in the clinic, different labs are going to have different normal values because they don't base it based off of just one standard value. They get their normal ranges from kind of the community. And lab will hopefully talk about all that with you, but on average, the normal is 40 to 45. Now, again, we're looking at the red blood cells per volume of blood, right? So red blood cells versus plasma. If we can sometimes kind of get this false sense of what's actually going on. And what I mean by that is, if we lose fluid, if we're vomiting, if we're having lots of diarrhea, we decrease our fluid, we decrease the amount of fluid that's in our plasma, and we can sometimes get this false hemoconcentration where we got this false elevation in red blood cells. It doesn't mean that we're making red blood cells more, it just means that we don't have enough fluid, so when we compare that, the whole thing together, we're going to have more red blood cells in plasma, right? So what can also happen though is if that happens, or if we give somebody fluids, or we give somebody an IV, or they're hydrating very well, we can also get this false decrease, right? And we call that hemodilution. So with that, again, we have more fluid, in our plasma that's going to dilute the amount of red blood cells we have. And so as a result, we can kind of get this false decrease. If you look at pull this up here. So if you look at these pictures over here on the right-hand side, this is kind of what you would see if they were doing some type of hematocrit test. Now this is kind of an old school way. Now they actually have analyzers that actually do that for them, but this is how they used to do it. But if you look at that, right, you can kind of see, so you got all these red blood cells here. Pull this thing up. So you got all these red blood cells here, and you got your plasma over here. And if you look at that, if you were to kind of eyeball it, right, you can see that that's about half of our plasma, give or take. On this side, you got your red blood cells here, you got this red kind of stuff in here. What do you guys think that is? It's hemolyzed, right? So because those red blood cells are hemolyzed, the contents of that red blood cell got into the plasma, but because the red blood cells were damaged, we don't have as many as we would have if it wasn't hemolyzed, so that concentration is going to be a lot lower. Now I talked about this yesterday. If you have a hemolyzed sample, what most likely would you have in that plasma that you, an elevated level of that you normally shouldn't? Potassium, right? All right. So then the indices, right? So there's a lot of indices for the red blood cell, and again, lab will talk about all this with you. But the ones we care about a lot, the ones we're going to use quite a bit, are going to be the MCV and the MCH. Now the MCV we're going to use a lot. That's going to be like your go-to. MCH you're going to use, but the MCV is really what I want you guys to kind of pay attention to. And all the MCV is it just tells us how big the red blood cell is. So if we have a MCV that's on the lower end, that tells us that red blood cell is going to be a lot smaller. If it's on the higher end, then it means that the red blood cell is a lot bigger. And if it's right in the middle, well then that's where we want it to be. It's a normal size RBC. And then the MCH, the mean corpuscular hemoglobin, that's the average amount of hemoglobin in each red blood cell. So we really use that to kind of tell us how much hemoglobin is in our red blood cells. So if we have a lot of hemoglobin in there, or if we have a normal amount, then we're going to have a nice kind of normal shade of our red blood cell. If we have a concentrated amount, then sometimes we can have an increased amount in our MCH lab. And if it's decreased, if we have decreased hemoglobin in there, you're going to get this hypochromic or this kind of light shaded red blood cell. So we'll use that to tell us how much hemoglobin is in each red blood cell. And then we got our reticulocytes. So reticulocytes, we make these normally. If you were to draw my blood right now, I would have a few reticulocytes, and that's normal, right? But what the retics do, so they're immature red blood cells that the bone marrow is kind of pushing out a little bit quickly. And there's a reason for that. We have to find a reason for that. If the bone marrow is pushing out retics, they're pushing out these immature red blood cells, why would that be happening? Why do you guys think?
Blood volume, trying to make more.
It's trying to make more, right? So we don't have the proper amount of red blood cells, and so our body's like, okay, we need to kind of expedite this. We need to get these red cells out. It's okay if they're a little bit immature. It's fine. They're still going to do their job, but we just got to push these red cells out as fast as we can. Now, in order to determine whether a red cell is a reticulocyte, you have to get a special study. You have to get, it's called a reticulocyte count. And what they'll do is, what the lab will do is they'll draw the blood, right? they'll stain it with this special stain, and what they're looking for are these RNA components that normally that red cell's going to get rid of, right? But because we're pushing it out so fast, we don't have enough time to get that RNA out. RNA is not going to damage the red cell, it's not going to cause any issues, but that's just how we identify that this cell is a reticulocyte count, or a reticulocyte. So when we have an increased reticulocyte count, like we said, there's something going on where we're losing blood or we lost blood, so our body's trying to push out these immature cells. Now if we don't, so say we are anemic, say we have a low blood count, we have, something's going on there, and we have a decreased retic count, then that means that the bone marrow is not doing what it's supposed to do. Either it's not, something's going on with it itself, that it can't make these blood cells, or we don't have the products that we need to make the red blood cell, to make the hemoglobin, okay? And so that's how you kind of delineate, if you are not sure kind of what the anemia is caused from, if you get a retic count, then that can kind of help guide, okay, which way am I going, which way am I thinking, what could be causing this issue here? So anemia, so when we talk about anemia, we got a few different things that can happen. So we can either have inadequate red blood cell production, we can have incorrect red blood cell production, so they're not making correctly for some reason, or we can be losing our blood, right? We can have some type of bleeding or something in our body is taking out our red blood cells. So anemia, right? So typically with anemia, you would expect to see a low hemoglobin. Hemoglobin is, like I told you, it's carrying the oxygen. Sometimes, or it says often here, now sometimes you'll have a low red blood cell count with that, but that's not always the case. If you have that, okay, that kind of helps you determine what's going on there, but that's not always going to be the case in clinic. So what causes it, right? So we kind of talked about the different causes already. You can have inadequate production, incorrect production, or something's taking them out. But when we look at our red blood cells, we want to know, are they small, are they just right, or are they too big? So are they microcytic, normocytic, or macrocytic? And no matter what the cause though, no matter whether it's a small, large, or normal size, normocytic anemia, you're still going to have the symptoms of anemia. You still don't have enough of the O2 components, enough of that product to actually take the O2 to our tissues. And so our patients are still going to present with the same signs. So they can have pale skin, right? They can have pale skin because we don't have that hemoglobin concentration in there, or we don't have enough red blood cells. And so if we don't have that component in our tissues, then we're going to be a little bit lighter, a little paler. Typically, if it's like a lot of blood loss, then you can see it in the skin. Now, if you look in the mucosa, that would kind of give you a better indicator because that's a lot easier to kind of see through, right? So sometimes we'll look at the mucosa to see whether or not somebody's truly having any type of, some type of pale mucosa or some type of blood loss. They're going to be short of breath and easily fatigued, and that makes sense, right? If we're not getting oxygen to our tissues, well, then our body is saying, hey, we need to breathe more, we need to get oxygen in, and so they're going to feel short of breath, and they may actually start having tachypnea, where they're trying to breathe a lot faster, or maybe they're having tachycardia because our tissues are saying, hey, we're not getting blood, we need to kind of get this blood a lot moving faster, and so our heart rate's going to increase as well. And I had this happen a few times, obviously, but I had a patient, he was like 20-something, 25, 26, and he came in and he was telling me that he was feeling fatigued and short of breath and having a fast heart rate. And I didn't believe him because when he was talking to me, he was, his vitals were great, he looked fine, but I got the history and I'm like, well, what do you mean? He's like, well, I just walked from the waiting area to here and I was out of breath. Okay, so as I get up, let's do a physical exam on you. He got up from the chair, walked from here to the exam table, and I saw it. He was like huffing and puffing, listened to his heart, it was going. I mean, oh shoot, this guy's not hard. So I sent him to the lab and got his blood drawn, and this dude his hemoglobin was like very low. It was very low. Long story short, this dude had a peptic ulcer. He was taking ibuprofen like around the clock. He had this problem with his testicles actually, that he just had this pain in his testicles, and we couldn't figure out what was going on. And the only thing that would help was ibuprofen. So he was taking this thing like all the time. We got him off that, obviously. His ulcer healed, and then he didn't need a transfusion, thankfully, but yeah, that was something that just kind of threw me off because you don't normally see that in a male who's pretty young. That's not typical. Anyways, the hemoglobin level values, again, take a look at those and kind of get a good idea of where that's at. If I give you lab values on the exam, I'm going to give you the normal range as well. Okay, so I don't expect you to try to memorize those values. You should look at the values, you should look at the range, and then based off that, kind of determine what's going on there. Because like I said, every lab you go to is going to be a little bit different. All right, so decreased hematopoiesis. So like I said, sometimes we can have problems with actually making our cells, our red blood cells, and that can be due to a few different reasons. If we have a bone marrow failure, so think about the bone marrow as like a factory, right? It's the factory that makes our blood cells. If there's something going on with that factory, if it's not working, then we're not going to make those cells that we need. There's also deficiency in nutrients. So we may have the factory, and it's on, but we don't have the supplies to make what we need in that factory. So if you think about it that way, maybe it's kind of easier to kind of put your head around. And there's a few different causes here. We'll get into the details here in the next few slides. So aplastic anemia. So this is a bone marrow failure. Something's going on within the bone marrow that's causing it not to make our cells. And typically when it's aplastic anemia, so if you think about, we talked about hyperplasia and we talked about hypertrophy and stuff like that. If you think about hyperplasia, I talked about how that increases the number of cells. Well, if we say aplastic, A, right, means no, play is the kind of gives you that key that, hey, something's not being made here. But with this issue, we have what's called pancytopenia, which means we're not having a reduction in all our cell lines. So the bone marrow makes our red blood cells, it makes our white blood cells, it makes our platelets. Because we have this aplastic anemia, not only are the red cells being affected, but we're also not producing the other things that we need that are normally made in that bone marrow. There's a few different causes for this. So remember that term idiopathic? I told you guys that just means, it's a fancy medical term that means that we don't know what's causing it. So there are idiopathic reasons where we don't know why this person is having aplastic anemia. Now that's super rare, but it does happen. But it can be frustrating because you're working these patients up and you can't find the cause. Well, how are you going to treat this? And I'll talk about that here in a second. And then we got secondary causes, right? So these are things that we're taking, or maybe some type of infection that we get that impacts our bone marrow, and as a result, it's not going to make the cells that it needs to make. Now, the good thing with secondary causes is that we can identify the cause, or if we're doing it ourselves and we stop that. So when I say doing it ourselves, sometimes patients have issues in their bone marrow that we actually want to wipe out their bone marrow, right? We're giving them radiation, we're giving them chemo because we're trying to wipe that bone marrow out because something's going on with it, that there's a cancer in there, right? And then eventually we're going to give them new bone marrow with the hopes that that bone marrow takes and it's going to start making normal cells. Viral infections. So I talked about mono, the Epstein-Barr virus. That thing is, we think about mono as like the kissing disease, or you get it with kissing or sharing drinks. Well, yeah, that's typically how you get it, but if that thing hides out in the body, then later on it can cause issues, especially with potentially aplastic anemia, but it can also cause lymphoma sometimes, like we talked about previously. Like I told you about that kid who he had that disorder where he didn't have any immune cells essentially. So mono is one of those things that most of the time we're going to get and then kind of get over, but sometimes it can cause a lot of issues. But anyways, so if we were to take a biopsy of the bone marrow with somebody with aplastic anemia, we're going to see that they're going to be hypocellular. They're not going to have many cells in there because our stem cells are not making them. Some took those stem cells out. But again, they're going to have the same characteristics of anemia. They're going to have that fatigue. They're going to have pallor. So they're going to have that that skin that's kind of it's not flush. They're going to feel weak because they're not getting oxygen to their tissues. But the thing you worry about with these guys is that because we're taking out the immune cells, the WBCs, and the platelets, you worry about infections. If you don't have your immune cells there to fight off an infection, well then a cold could take you out, or COVID can take you out. Something minor that we normally get, that we have our immune cells to fight off against. If we don't have that stuff in place, well then very small, easily treatable things can take out the person and cause death. Again, if you're taking out your platelets, you need your platelets to help that blood clot. If you're taking them out, then you can have these bleedings that occur. And so most of the time, if we don't treat this in time, that's what these people are going to die from. They're going to die from either some type of infection, or they're going to bleed out, they're going to bleed out in their brain, they're going to bleed out in their abdomen, and so that's why this thing is super dangerous. Now, if we know the cause, right, if it's a secondary cause and we're able to treat it or we're able to stop what's going on, then typically that's fine. Their bone marrow can recover. But if we don't know the cause, if we don't know what's causing this, how are we going to treat this, right? The best way to do that is with a bone marrow transplant, where we screen another person, right? Typically, most of the time it's somebody close to that person, but it can be anybody. You got to make sure that their bone marrow matches to this person. It's not going to cause any type of immune reaction. And then we transplant that bone marrow into that patient, and then the hope is that that new bone marrow starts to take root, it starts to form these normal red blood cells and platelets, right? Okay, so up here it says, would the reticulocyte count be high or low in this case? So we got a problem with the bone marrow. It's going to be low, right? We're not making the red blood cells as it is, so how are we going to make these retics? It's going to be low. All right, iron deficiency anemia. So this thing, you're definitely going to see this. This thing is probably, you're going to see it maybe once every couple of months. More often than not, it's going to happen in females, but if it happens in a male, again, that should kick you off to something, and I'll explain what I mean here in a second. So normally, when this happens, it could be due to a few different causes. It could be one or more of these, but typically one of these three. Either we have increased iron loss, right? And that could be due to, we're bleeding out somewhere. Maybe we have a slow bleed. Maybe we have a bleed in our GI system, and we don't know it because when we're pooping, we see black still. We don't know what that is, right? We think that's normal. Or you can have some type of, especially in females, right? Some women have heavy menstrual cycles, and so when they have their cycle, they bleed excessively, and when they're bleeding excessively, they're losing a lot of iron because that iron is stored, most of it is stored in your red blood cell. And that iron, typically when the red blood cell dies, our body takes the iron, recycles it back to our bone marrow to be used again. If we're losing that blood, we don't have that iron anymore, we don't have that storage to actually be recycled. If you're not taking it in properly, so if you are, if you don't eat red meats or if you don't eat leafy green vegetables, if your diet is poor, you're not getting enough iron into your body, well then that's obvious, right? You don't have the iron, and you may have some iron in your red blood cells, but you're not replacing that, because eventually you're going to use that iron over the long haul. And so we can have anemia that way. Or if you have some type of malabsorption issue, so if celiac disease, we'll talk about celiac when we get to GI, but that's an autoimmune disease that typically affects that small bowel. That small bowel is where we actually absorb the iron. So if we have some type of inflammation, damage to our small bowel, well then that could cause issues with us absorbing iron. If we have an increase in our iron requirement, so pregnancy, right? That's why when somebody's pregnant, we're giving them these prenatal vitamins that help a whole bunch of stuff in, and iron is one of them because that baby needs iron as well. And that baby's getting that iron from the mom, and so mom has to replace that iron that is given to the baby. If you have surgery, right? If you bleed a lot, you lose all that blood, well, you need iron, and so oftentimes we'll get some type of supplementation, especially if they've had a lot of blood loss. Now the problem here is that iron, like I told you in the beginning of the lecture, when I showed you guys the hemoglobin, and it has that iron in it, it has that heme group. Well, if we don't have the iron in that hemoglobin, in that globulin, then we're not going to make the hemoglobin correctly. We're going to have a decreased amount of hemoglobin because we need that iron in that heme to actually make the hemoglobin. And so as a result, if we don't have a lot of hemoglobin in the red blood cell, it's going to be small. It's going to be microcytic. It's going to have a decreased MCV because we're not filling that red blood cell with the hemoglobin that it normally should. It has some in there, but it doesn't have the normal amount, and so it's going to be a lot smaller. It's going to be hypochromic as well. It's going to have it's going to have less color because again, that hemoglobin is what gives that red blood cell that color. And if we don't have the proper amount in there, it's gonna look a lot lighter. You can also get these things called target cells. So sometimes what will happen is that you're making hemoglobin. If you make the normal amount of hemoglobin, that red cell is gonna be flush, it's gonna have the full amount of hemoglobin. But with the target cells, sometimes that hemoglobin it doesn't cause that red cell to be flush. It kind of disperses throughout the red blood cell. So it has this like target appearance. It looks like a target. And I'll show you a picture here in the next few slides. Like I said, this is more common in women, definitely more common in women. But if you have it in a male, you should be thinking, because men don't have a menstrual cycle. If it happens in a male, most of the time it's due to some type of bleeding that's going on. Typically in the GI tract, especially in your older men. If you have an older male who has anemia, you gotta be thinking, okay, why are you bleeding? Do you have an ulcer? Do you have colon cancer? Because most of the time, like I said, men are not gonna be losing iron, losing their red blood cells unless they're having some bleeding going on. Now normally we can treat this, right? If somebody's iron deficient, all we have to do is just replace them give them the iron. There's different ways of giving iron. You give it pills. You sometimes do IV infusions if they can't tolerate the pills. But you can't stop there, right? You can't stop there, because if you stop there, how do you know what's going on, right? How do you know what's going on? I had a patient again one time. She had fibroids. She had these kind of tumors in her uterus. These are kind of benign tumors, right? But sometimes they can cause excess bleeding when you have your menstrual cycle. And I told her, we knew what was going on. But she had anemia, right? She had pretty bad anemia, and so she would go to see a hematologist and get these infusions of iron because she couldn't tolerate the pills. So I told her, and she was older, she was done having children, and I said, hey, have you thought about getting a hysterectomy, just taking out the uterus, and then problem solved, you don't have to worry about getting these infusions anymore. And she's like, no, I don't want to do that. I forgot why she told me she didn't want to do it. And then she got an assignment to be like a commander of a base, and it was somewhere not in the States, and so because she needed those regular transfusions, and because she was going somewhere outside of the U.S. where she wouldn't be able to get that, because where she was going was kind of remote, there was a potential of not giving her that assignment. So we worked with her and said, hey, if you need these transfusions like you do, these IV transfusions, that probably can't send you out there. Because if you go out there, you're not going to be able to get it. You're going to become anemic, and if you become anemic, severely anemic, where are you going to get your care? Because where you're going is not a big place. So she ended up going through. She talked to OBGYN. They ended up doing hysterectomy, and then she was good. She no longer needed her iron transfusion because we stopped that source of bleeding. Like I said, you got to figure out what's causing it, because if you don't, then you may be missing something. All right, so megaloblastic anemia. So this is more of a macrocytic anemia. This is where your red blood cells are going to be large. And there's a few different reasons why this happens. So B12 and folate. B12 and folate are very important for DNA replication. And when we don't have enough of this, then it can sometimes cause our DNA to replicate slowly. And as a result, what it can do is actually cause our red blood cell to become larger, because the DNA is trying to replicate, it's going slow, but that cytoplasm is still doing its thing. And if that red blood cell gets too large, then you can get these things called megaloblasts. And they're like an immature, typically we don't have these, they're an immature type of red blood cell. And when the body sees these megaloblasts, it's going to say, hey, you're not normal, let me get rid of you, right? Now sometimes these megaloblasts are actually able to go through full maturation, and so as a result, because you already had this large cell, that red blood cell you're going to get is going to be a lot larger. But the problem with this is that our body, our spleen, takes out too many of these megaloblasts, and so we're left with a decreased amount of red cells. They're bigger because of the way the DNA replicated and cause issues with the cell actually, the way it grows, but we don't have enough of them. So it's not the hemoglobin that's the problem here, it's the fact that we took out too many red blood cells because they looked abnormal. So the way this happened, so B12, so you've heard of, you've all heard that vegans sometimes can become anemic, potentially if they're not eating certain products or not supplementing. This is the problem. So if you have a diet, because B12 is normally found in meats, and eggs, dairy products, and animal products, if you're not supplementing this, then this is one type of anemia that especially a vegan can get. Again, if you're not absorbing this correctly, say you have some type of issue with your small bowel, like celiacs or Crohn's, and we'll talk about Crohn's in a few blocks as well. Then if you're not absorbing it, you're not able to actually get that B12 into your intestines and into your body. So that can cause issues. There's something called pernicious anemia. So this is an autoimmune disease where our parietal cells, they normally make our acid, right? Sometimes our body can actually attack our parietal cells, so it will cause issues with the acid production, but the parietal cells make something called intrinsic factor. And intrinsic factor is absolutely needed to actually help absorb that B12. So if we're destroying our parietal cells, we're destroying that intrinsic factor, we're not going to be able to absorb that B12. Folate, so most of the time in our diet, we actually get, our foods are actually fortified with folate. It's called folic acid, it's like man-made folate. So that's why it says cereals here, but then also naturally they occur in vegetables. Now if you're pregnant, again, the baby needs essentially everything you need, so it's going to start taking that folate from the mom, and if it's taking that from the mom, well, then we need to supplement her. So that's why these prenatal vitamins have folate in them. If she's breastfeeding as well, she's burning a lot of energy, again, passing off what she has to the baby, that can cause issues. Ethanol abuse or alcohol abuse. So think about alcoholics, right? If you've ever had anybody in the family who's an alcoholic or a patient, right, or dealt with a patient with that, sometimes they prefer alcohol over food. Right? I mean, that's especially when it's severe. And so if they're just drinking, whatever they're drinking and not eating, that can cause issues with folate deficiency. And then also too, alcohol, it damages the intestines. It causes inflammation. And if we damage our intestines, if we damage our small bowel, well then we're not going to be able to absorb that nutrients like we should because there's too much damage. Now, the other thing so like I said, these deficiencies can cause those red blood cells to be larger, so we call that macrocytic. But something else that it does is it doesn't just affect the red blood cell, it affects our neutrophils. So we get these things called hypersegmented neutrophils. And all that means is that if you were to look at a neutrophil, because normally it has the nucleus, right? With these type of neutrophils, because it's affecting the way that DNA is replicating, it's going to affect that nucleus. So you're going to get these kind of hypersegmented. It has all these little kind of deviations, and I'll show you a picture of what that looks like. So when you see a macrocytic red blood cell, and then you get a report that also says that there's hypersegmented neutrophils, you should think, okay, maybe this is a B12 issue, or maybe a folate issue. But again, it's going to cause the same symptoms as anemia. Like we talked about anemia already, they're going to feel tired, they're going to have pallor, they're going to feel short of breath, so same thing. Now the thing with this is that, depending on the cause, we can either treat them with B12, we can give them shots, or we can supplement them. But again, if you need to figure out what's causing this, because we may be masking a symptom, we may be treating it, but if we don't fix the issue, well then they're going to have this lifelong. And I'll say with pernicious anemia, because that's one of those things that people often will just kind of give B12 but not actually investigate. This can cause issues later on down the line and potentially cause gastric cancer, potentially, right? So that's why you really want to try to figure out, okay, what's causing this? If it's pregnancy, okay, she's going to deliver eventually. We supplement her, she'll be fine. But if we don't know if this person's not a vegan, it's a B12 issue, okay, why is that happening? Because that's not normal. So you gotta try to figure out what's causing this. So just an example, so iron deficiency anemia. So these are those target cells I talked about. So it looks like a kind of bullseye, right? Down here, you can see that these red blood cells, it's kind of hard to appreciate, I think, but these are supposed to be macrocytic, so a lot larger than, you'd have to kind of look at the other red cells, and it's a lot easier if you're looking at it under a microscope. Now typically, when you get a report back, if you order a lab, it's not going to say macrocytic and stuff like that, it's going to give you the MCV value. But sometimes there will be a differential on there, or sometimes there will be a pathology review because the lab saw something that's not typical, and so they'll send this to a pathologist. Pathologist will do a smear, and then they'll give you an additional report saying, hey, We also saw hypersegmented neutrophils or whatever type of abnormalities. So, but most of the time you have to rely on your indices, especially your MCV and MCH. All right, so abnormal hematopoiesis. So now we're talking about incorrect red blood cell production. Now most of the time this is from some type of genetic issue, some type of genetic error. And we got sickle cell anemia, we got thalassemia, and we got something called hereditary spherocytosis. So sickle cell anemia. So this is going to be more common in people from African descent or the Mediterranean area. What happens here is that you have this defect in that beta globulin, right? So we got the alpha and the beta normally. Well, there's this defect in the way that beta globulin is made that when it combines with that normal alpha globulin, or the alpha chain, which is another way to say globulin, then you're going to get something called hemoglobin S. Now this is typically an autosomal recessive disorder, which means you have to have two defective genes from your parents to inherit this. But it's a little bit different, and I'll explain what I mean there in a second. So with hemoglobin S, right, when we stress that red blood cell, whether it's from low oxygen, which is a very common, I don't think that's on here, but you should know that low oxygen kind of states can cause that. Or if they're dehydrated, or if they're exercising vigorously, anything that stresses your body can potentially stress out the red blood cells. When it does that, what it causes that hemoglobin S to do is it starts to cause it to aggregate. It starts to cause it to kind of fill in on itself in kind of this chain-like pattern. And when that happens, it's going to cause that red blood cell to deform into the sickle-type shape. That's why it's called sickle cell. Now, when that cell sickles, I told you already that our capillaries, typically they're one cell wide, and normally the red blood cell, when it's traveling through, it normally has that bioconcave shape. It's going to allow it to pass through easily. When it's sickled, it can't do that. It's too abnormally shaped, and sometimes it can block those capillaries. And if it blocks, especially in our spleen, if it blocks the capillaries in our spleen, then what it can do is over time cause these kind of chronic infarctions, cause these chronic ischemic episodes that eventually cause that spleen to die. And when the spleen dies, it's called an autosplenectomy. So essentially it's a non-functioning spleen. You didn't take out the spleen, it just had too many episodes of infarction that now it doesn't function anymore, now it's dead. Now, normally with this, and the other thing too is that when that red blood cell sickles, it may not hemolyze, right? It may, once that stressor goes away, it may go back to normal. But after repetitive episodes of that, it's going to start to weaken that membrane of that red blood cell. And so it's going to potentially easily hemolyze from, just kind of movement through the body. So the more that red blood cell sickles, the weaker it's going to get, and then eventually it's going to hemolyze. Now normally we don't notice this during a fetal development, right, or when a child is born, because normally as the fetus, once the baby's born, they still have hemoglobin F, but it's going to take time for that hemoglobin F to change into that hemoglobin A. It's going to take time. It typically takes about 6 months to a year. So most of the time we don't notice it unless we have some idea and we do some type of genetic testing beforehand. But granted that, we won't know it until that baby starts to develop that hemoglobin S, because they don't have that normal hemoglobin A. Now, right below that, right here, it says patients with less than 40% of total hemoglobin S are often asymptomatic. This is referring to hemoglobin trait. You can have the trait for this. You can have one defective gene, and you can have one normal gene. But because you have the trait, because I told you normally, if you have two recessive copies, then you'll demonstrate it. If you have a normal and one recessive, then you won't. This is a little bit different. If you have one abnormal copy and one normal copy, you can still make hemoglobin S. And in fact, in the military, we have people who have sickle cell trait. And I don't know how it is in the other services, but in the Air Force, if we identify that whenever you come through and you're going through boot camp and all that stuff, and we're doing all the blood samples, we have to identify you. And then if you have that, you have to come see us at least just twice throughout your career. I don't know why it's just twice, but you have to come twice, and you have to get counseling before you take your PT test, because potentially, it doesn't happen always, but it can happen. Potentially, if you go when you take your PT test and you really exert yourself. Now it's Air Force PT test, but sometimes it's hot, right? Sometimes it's hot. But if you stretch yourself too much, then sometimes it can cause those people to develop sickle cells. But it's rare, it doesn't happen too much. But definitely sickle cell disease, that's one of the things you can't have in the military, and if you have it, we find it somehow, we didn't catch it before, then you're not going to be in it. Because we put people in too many places where they potentially get stressed and cause these sibling things. Sickle cell crisis. So all this means is that you have this kind of mass sickling of your red blood cells, and when it does that, it can kick off this kind of inflammatory response. It can clog up a lot of capillaries, so in our bones, in our chest, in our heart, in our wherever, right? And so if that happens, that's not good. We need to. Typically, people are going to come in with a lot of pain because they're not getting that blood flow through because areas are coming to get ischemic, and we're going to get them to the hospital and hydrate them, give them oxygen, just to try to get that crisis to stop. If the sickle cells actually hemolyze, they're obviously at increased risk for anemia because we're damaging those red blood cells. The hemoglobin is going to break down. You can develop jaundice from that hemoglobin breakdown, so it's yelling at the skin and eyes and mouth. And then gallstones. So gallstones so gallstones, as we'll talk about in the GI lecture, gallstones are made from a few different components, but bilirubin is a component of that. And so if we are breaking down the red blood cells, making bilirubin, which is causing jaundice, and we have a lot of bilirubin that builds up, it's going to go into our gallbladder and create these gallstones. And if we have gallstones, most of the time, most of the time if they have a gallstone, okay, cool. But because if they're asymptomatic, we don't have to treat that. But sometimes that gallstone can block that gallbladder, and it can cause necrosis, or it can cause that gallbladder to swell. And so patients are typically symptomatic at that point, and we're going to go ahead and treat that. But I guess what I'm getting at is that sometimes they can have an increased risk of developing gallstones from that hemolysis. Splenic sequestration crisis. So this one's kind of a dangerous one. So if those sickled RBCs clog the splenic outflow, right? If it clogs the ability for that spleen to, because the blood's going to be flowing through our spleen like normally, and that spleen's job is to make sure that what's passing through there is normal, or if it's abnormal, it's going to take it out of circulation because you have a lot of white cells in there. So the spleen's like this big filter. It's got a lot of immune cells, and its job is just to make sure that whatever's going through your blood is normal. And if it's not normal, those cells in the spleen are going to take it out of circulation, get rid of it, right? If we block the outflow, then what can happen is that spleen can actually start filling up with the blood that's traveling through there. As it starts to fill up, it's going to cause that spleen to become huge, right? Because now the blood's not flowing out, it's getting caught in the spleen. And I'll show you a picture towards the end of it. Maybe you've seen it already, you flip through the slides, but I'll show you a picture of a pretty big spleen. That spleen can get pretty big. If we block that outflow and that spleen starts to swell, that can contribute to a low blood volume, right? We don't have any more blood going past the spleen. And as a result, they're going to have anemia because we're not getting red blood cells past the spleen. We're going to have a drop in that blood pressure because all that blood is being trapped by the spleen, and they can develop hypovolemic shock. So that's another kind of thing that can cause hypovolemic shock is this splenic sequestration. Now, typically this happens in children. It doesn't really happen in adults. I don't know why. But this is one of those things that, especially for kids, you got to be careful of. Okay, so treatment, right? How do we treat this? Well, obviously we want to try to avoid the triggers. That's why, like I told you, in the Air Force, we counsel our patients who have this. Just not so much because they got to take their test, right? Not so much that they can't take their test, but just to say, hey, this is what you got to look out for. If you go take that test and you start to experience these symptoms, you got to stop, let your person know, and then get you to the hospital. Hydroxyurea. So hydroxyurea is one of those drugs that you'll talk about called pharmacology. But essentially what that does is it helps the body make more hemoglobin F, right? So it kind of shifts that red blood, or the hemoglobin production from hemoglobin S to hemoglobin F. Now hemoglobin F, you would think that that's better. You would think that it's better, right? Because I told you already that the baby needs it because the baby has to take the oxygen from the mom's red blood cells. But the problem with hemoglobin F, especially in an adult, is that its affinity for oxygen is very strong. So when those red blood cells try to pass through the tissue, it's not going to let it go as easily, right? So that's why we don't want that as an adult typically. But hemoglobin F is better than hemoglobin S, right? So this is preferred for our sickle cell patients. The The only cure for this is a bone marrow transplant. So if we take out that bone marrow and replace it with better bone marrow, then we can potentially cure this. But it's hard, right? It's not simple just to go and say, hey, it's not like blood typing and cross matching. This takes a lot of steps. There's a lot of stuff you have to do to make sure that bone marrow is compatible with the patient. So it's not as easy as it sounds, because if it was, then we wouldn't have this anymore, right? We treat all our patients with this. All right, so just let me get through this slide. So just anemia, or just sickle cell, right? Just an example. So this is, you see there, we still make that beta globin, right? We still have it, but there's a defect in it. So because of that defect, it's going to cause those cells to sickle. And so if we were to give them hydroxyurea and they're going to make hemoglobin F, well, they don't have that beta globin hemoglobin F. That's why these cells don't sickle. That's why it's better for the patient. And it's an example of, you got hemoglobin here, you got hemoglobin S, you get this what's called polymerized. Polymerized, all that means is that the molecules of hemoglobin are just linking together and forming this chain. That's all that means. But when it does that, it creates this sickling shape. And then you got pictures here of actual what these look like under the microscope. So kind of over here, and then this is kind of more elongated, but they're not nice and round. They're going to be this kind of long, sickling looking shape. Cool. All right, let's take a 10-minute break.
We are just becoming a developing pot, right? As far as resuscitation. So how does something like sickle cell anemia, you just have to cast a wider net, because you can't just outright say, oh, I have something compared to certain individuals that they might have this. Yeah. So obviously, yes, I did. I mean, fire both. Yeah, you're right. That's great, right? And that's obviously more than It's just really not good competition.
All right, let's get started. We're about halfway through, so I can do this some next 50 minutes. All right, so kind of continuing on with the abnormal hematopoiesis. So thalassemia. Thalassemia is another one of those things that can cause abnormal red blood cells. Now with thalassemia, the problem here is not so much the hemoglobin that's being made, it's the amount of hemoglobin being made. So we can have two forms of this. We can have alpha thalassemia. We call it alpha thalassemia minor, or you may see it's called trait as well. So both of those names are accurate. Or you can have beta thalassemia minor or trait, right? Same thing. Or you can have beta thalassemia major. And again, it's the problem with the globulin chain of the hemoglobin that's being made. So for alpha thalassemia minor, you typically have a reduced amount of the alpha chain, right? Now, with beta thalassemia, it's the beta chain that's being not made in enough. Now you can have different forms of the beta thalassemia trait. You can either have, trait or major. You can have a lot of beta globin not being made, or very little, right? If you have the minor form, if you have the trait, most of the time the patient's going to be fine. Most of the time you may not even know it. Most of the time when this happens, actually, you're working this patient up, you're getting some type of blood draw for whatever reason, and you're going to see that they're going to have these small red blood cells, and they're going to have hyperchromic red blood cells as well. And you're going to think maybe this is an iron deficiency anemia, right? And you're going to do your iron studies, and you're going to see that the iron is actually normal. And so then it's going to lead you to, okay, maybe this is thalassemia. Now the major form, that's different. With major, these people typically have very severe anemia. They often don't make it past infancy. If they do, they're going to have a lot of issues. They're going to have heart issues because they don't have enough of the hemoglobin being made, and so they're not getting the oxygen that they need. So what the body's going to do is tell the heart, start pushing out as much blood as you can. I want you to beat fast, I want you to beat stronger. And over time, the heart can't take that. The heart has this normal rhythm, right? It has this normal rate. But if it's constantly beating out, forcefully contracting, it's going to cause these heart changes to occur, which can potentially lead to heart failure and death. With the trait, you don't really have to do anything though. If you catch it, if you see it, okay, good to know. And I say this because there will be patients who will come to you and they're going to come in because they were told in the past that they had iron deficiency anemia. And then they want their iron refill, right? And you look back and you're like, well, how do you know that? Somebody in the past told this patient that they had iron deficiency anemia, and they started treating them for iron deficiency, but they never worked them fully up. The way you want to work this up is that you have to get something called hemoglobin electrophoresis. If you do that, if you have somebody who you suspect has this, and you get this test, what this test will do is tell you what type of hemoglobin that you have in that red cell. I'll tell you this in a second. So most of the time, like I said, you don't really have to treat the trait because how do you treat it, right? If you give them iron, it's not going to do anything. So here's an example of hemoglobin electrophoresis. So over here, we have our normal hemoglobin, right? We have, normally we have A, a little bit of A2, and like I said, sometimes you can have a little bit of F, sometimes you won't. It doesn't matter if you do it up or don't. With the trait, with beta thalassemia trait, you still have hemoglobin A being made, but you have a little bit more A2. Our body's going to use a different pathway to make a little bit more A2. but it does the same thing, right? You still have enough A for the body to actually work, for that hemoglobin to get to the tissues, for the oxygen to get to the tissues, so you don't have to treat this. For major, this is the problem, right? We don't have this A. We don't have this A anymore. We have a little bit of it, but we don't have the normal amount that we normally do. We still have some A2, because these are different types of globulins, but we're gonna make a little bit more F. But that F is not the best, right? We already said that, like, it's better than sickle cell, it's better than simple hemoglobin, but it's not the best thing. For the trait, so I talked about sickle cell trait, right? So you still make a lot of A, you still make a lot of the normal hemoglobin, but you also make some sickle. Now most of the time this is not going to be an issue unless potentially you really stress that body out, but again, most of the time it's not going to be an issue. Versus sickle cell anemia, you have no A, right? You don't have that normal beta globin, and so we have this other form of hemoglobin called hemoglobin S. We have some more F, and if we give them hydroxyurea, then we're going to have more F than that. We still have some A2 because that doesn't have the globulin in it. So this is the way you can, if you think somebody potentially has anemia, and maybe you don't know if it's thalassemia or if it's iron deficiency anemia, then you can do the hemoglobin electrophoresis, and that will give you an answer. And it's a quick test. It's a very simple test. Lab will send it out. You'll get a report back, and then you'll know what's going on with this patient. And then maybe, especially if that patient's taking iron, you can say, hey, you don't really need this, it's not doing much, and one less thing they got to take. But there's nothing you have to do for the trait. Major, you're not going to be really managing that. That's going to be hematology if they make it past birth. Okay. So last thing for abnormal hematopoiesis, so hereditary spherocytosis. So this is a problem with the red blood cell membrane. It's a problem with a few proteins in the red blood cell membrane. And when we have this problem with that protein, there's several of them, and you don't really have to know which ones they are, but when we have that, our body is going to make these smaller spherical type of red blood cells. So I told you it's normally bioconcave. These guys are going to be like little round balls, and they're going to be smaller. But because they're shaped the way they are, when they pass through our spleen or when they're passing through our capillaries, they're going to break easily. They're not as flexible. So because of that, you're going to have symptoms of anemia because our spleen's trying to get rid of them, or they're causing hemolysis. You're still going to have the microcytic findings because they're still small red blood cells. But the difference here is that they're going to be hyperchromic because you still have hemoglobin in there. It's not the problem with the hemoglobin, it's the problem with the actual membrane of the red blood cell. So when you look at it under a microscope or when you send it to the lab, they're still going to have they're going to have either the normal amount of hemoglobin or they're going to have an increased amount because you're concentrating that hemoglobin to a smaller packed cell. So if you see down here, right, normally that red blood cell count is going to be a little bit decreased because our spleen says, hey, these look abnormal. These aren't our normal. These aren't normal red cells. Let's get rid of them. The hemoglobin itself is going to be decreased potentially because, again, we're taking out a lot of red blood cells. So if we take out the red blood cells where that hemoglobin lives, then we're going to have a decreased amount of hemoglobin. And that MCH, it could be normal or it could be elevated because we're packing in that hemoglobin into a smaller space. So if you see a microcytic anemia, right, how do you delineate between iron deficiency anemia and this?
Hyper versus hypo.
Exactly, yeah. If you look at the MCH, if you look at the report and you see that it's either hypo or hyper, that should kind of delineate where you're going with this patient. So here's an example of, again, this is normal over here, and if you look at these red cells over here, they're a lot smaller. And again, it's hard to appreciate that with this picture, but if you were to, again, look at it under a microscope, it would be a lot easier to kind of compare it. All right, so loss or destruction of red blood cells, this is the other causes of anemia, and this makes sense, right? If we're losing our blood, if we get, something happens and we lose a ton of blood, we're bleeding out, well then we're going to have a decreased amount of red blood cells because it's no longer in our body. Now, there can be acute or chronic causes. Acute, okay, something happened, we're bleeding out quite a bit, makes sense. Chronic, these can be these slow bleeds, right? These can be these slow bleeds that are happening in the GI tract, in our colon, in our stomach. And so maybe it doesn't develop for a while, but if that bleeding is ongoing, over time we're going to start losing these red blood cells, and so we're going to start becoming anemic because we no longer have them in our body. Destruction of red blood cells, so malaria. So you guys talked about malaria last semester. So that plasmodium, it can affect the red blood cells, it's going to cause it to lyse eventually, so those break down. Medications, G6PD deficiency, that's an enzyme that we normally have. Some individuals don't have this enzyme. This enzyme is important because sometimes when we take medications like anti-malaria drugs, those metabolites from that medication breakdown can actually cause these metabolites that can actually damage the red blood cell. So that G6PD, that enzyme, is important to kind of help protect it from that happening. So if we're deficient in that, then we shouldn't take these medications. And that's why when we join the military, everybody's screened for this deficiency because we like to go places where malaria is at, right? And so we have to take these medications sometimes. And if you are going somewhere and you have this deficiency, we need to know because then that kind of guides where you go or what we give you. Hemolytic anemia, we talked about that a few blocks ago where we have the autoimmune destruction of our red blood cells. And then that splenic sequestration, again, mostly you're going to see that with sickle cell. You can see that with severe specialists as well. Again, our spleen is just seeing that as abnormal and it's taking out those red cells because it thinks that we can't use them because they're just abnormal. Here's a table for you, just to kind of help you when you're studying, just to compare where's what. The one thing I want to point out here is that when we talk about the chronic blood loss and the acute blood loss, so chronic blood loss, right? If we are chronically losing blood and there's a lot of, we're not keeping our iron, it's not being recycled, well, if we don't have that iron in place, then we're not going to make that correct amount of hemoglobin, and so those red blood cells are going to be small, right? So slow bleeding, chronic bleeding, we're losing our iron slowly, we're not going to make the hemoglobin like we normally do. Versus acute blood loss, that's typically going to be normocytic. You lost blood right now, it's gone, we checked your blood right now, you still have those red blood cells from a week ago when you weren't bleeding, right? So they still have that normal amount of hemoglobin that's being produced. You may have less of it, but if you look at it, if you look at the shape of that red blood cell, then it's going to be normal. It's going to be a normal appearing red blood cell. You just have less of it. So that's the difference between acute and chronic. All right, so polycythemia, leukopenia, and leukocytosis. So polycythemia, all this means, so the word polycythemia, all that means is that there's an increased amount of red blood cells. So you have more than normal. There is a product produced by the kidneys called erythropoietin. You've heard of that, like Lance Armstrong, he was taking EPO to help boost his red blood cells so he could win his races. So normally the kidney makes that, right? The kidney is telling the bone marrow, hey, I want you to make red blood cells. Here's some erythropoietin. The bone marrow is going to take that and start making its red blood cells. But there are two things that can cause polycythemia. There's primary polycythemia. It's also called polycythemia vera, or the secondary causes. The polycythemia vera, this is a type of bone marrow cancer, right? It's a type of malignancy in the bone marrow. And without erythropoietin telling it to make the red blood cells, it's going to make them. But it's not only going to make the red blood cells, it's affecting the stem cells of our bone marrow. So it's making a lot of red blood cells, it's making a lot of white blood cells, it's making a lot of platelets. It's affecting those stem cells. And I showed you that first picture where the stem cells delineate and they go to different pathways. Well, there's this one stem cell that makes all of that. So when that thing starts to become impacted with this cancer, then we're going to have an increased amount of all our blood cell lines. Versus secondary polycythemia, this is typically due to some type of increased erythropoietin. And there's a few things that can cause this, right? So if we have some type of problem breathing, and I'll use sleep apnea as an example because you can see this when sleep apnea, it's where when you're breathing at night or you're sleeping at night, your airway can collapse, right? And so throughout the night, you're getting these low periods of oxygen. Well, our body can sense that. When it senses that, it can tell our bone marrow, hey, we don't have enough oxygen, make some more red blood cells, and it's just the red blood cells that's occurring here, it's not the other ones. Make some more red blood cells, that way we can start to oxygenate our tissue. If you go to a high altitude area, so Colorado, I just came from there, right? Sometimes, especially when somebody just got there, they would start to, because the oxygen pressure is a little bit less up there, not but sometimes you would see that these people come in with just a little bit of an increased red blood cell count. Most of the time, after they've been in for a while, things are going to come back down, but you don't really have to do much when it's due to that reason, because what are you going to do, right? They're going to be fine, but you can see a little bit of an increased red blood cell count when that happens. Or there can be an ectopic reduction. So I already told you that erythropoietin is produced by the kidney, but you can get these certain cancers in the kidneys that make this stuff without any type of signal from the bone marrow. And so this thing is going to be making, this cancer is going to be making erythropoietin, and it's going to keep making it, it's going to keep making it. And even though you're making all these red blood cells, typically there should be some negative feedback that says, okay, we have enough. Well, this cancer cell is making the erythropoietin, and so your body's going to just keep making red blood cells. So this is one of those neoplastic syndromes, right? Remember we talked about that a little bit, where this may be the first sign. Patient may be fine, but you draw their blood and they have all these red blood cells. This may be the first sign that maybe something's going on, maybe it's some type of renal cell cancer. Splenomegaly is a prominent feature. So when we're making that, again, our spleen is going to see that as abnormal. It's going to try to get rid of them as much as it can. But, and it may be able to, but if you're making too many red cells, it's going to overpower that thing, and then that's when it's going to keep getting bigger and bigger and bigger. We treat this, so it depends on the cause, right? So primary, if it's cancer, well then we're going to treat whatever cancer is going on. Or we can actually take out the red blood cells. So we can do some type of therapeutic phlebotomy where we're just removing those red blood cells. If it's a secondary cause, then we need to figure out what's causing it. And again, if it's some type of adaptation or altitude issue, not a big deal, they're going to be fine. But if it's sleep apnea, okay, we treat the sleep apnea, that goes away, great. If it's cancer, we remove the cancer, hopefully remove it all the way, and then it goes away a little bit. So just some definitions. Leukopenia, all that means is that you have a lower than white blood cell count than normal. It can be due to a lot of reasons. Probably the most common ones are certain types of cancers, and then if we're treating cancer, radiation, chemotherapy. Leukocytosis, all that means is that there's an increased amount of white blood cells. Most of the time that's from some type of infection or inflammatory process. Neutrophilia, that just means increased number of neutrophils. Eosinophilias for eosinophils. And lymphocytosis, typically that's lymphocytes, and that's typically due to some type of viral illness. So leukemias. So we're not getting into leukemias. You're going to have hematology oncology, I think, your senior semester. They're going to talk about all those types of leukemias. They're going to get into detail with that. We're just really going to focus on lymphoma and multiple myeloma. I know somebody asked me yesterday about memorizing incidents or knowing incidents. I think for these you should. I think for the lymphomas and the multiple myeloma, they're the ages, right? That's all that is. And so it's going to help you delineate what is what potentially. So I don't want you guys to ignore the ages for these groups of disorders. So lymphoma, right? So there's different kinds of lymphoma. We got Hodgkin's and non-Hodgkin's. With Hodgkin's lymphoma, this one's weird. This one's a little bit weird. Because you see there that it has a bimodal age distribution, meaning it's going to peak. Most of your patients who have lymphoma it's going to occur around the ages of 25 and 55. Now, if you look at that green graph, that doesn't mean like you can't get lymphoma other times of your life. That's just when most of the time you're going to see your patients with this disorder. There are subtypes, and these subtypes kind of get into the way things look under the microscope. Don't worry about that. Don't memorize that. I just want you to know that with Hodgkin's lymphoma, it has certain features. Now, we talked about our lymph nodes, and we talked about how if they are growing slowly and they're not painful, right, that could be a sign of cancer. So with Hodgkin's lymphoma, textbook, you should hopefully see that they have some type of enlarged lymph node that's typically not painful, right, because we have these lymphocytes that are just proliferating in that lymph node, and it's growing slowly, and it's slowly stretching out that capsule, so it's not going to cause that pain you would see with some type of inflammatory or infectious process. Typically, it's going to be in the neck, anywhere in the neck, really. It could also be in the mediastinum, so kind of deep within near our lungs and heart. Now, the thing about Hodgkin's lymphoma is that this one, when it starts off at one lymph node, it starts to spread continuously. So it goes from one lymph node to the next, to the next, to the next. But the thing you need to know this for sure. Again, not talking about for testing purposes, but for parents for sure, because they always like to ask this question. They have these Reed-Sternberg cells. This is what makes Hodgkin's lymphoma Hodgkin's lymphoma. It's these specific cells. All these cells is that they're lymphocytes that have fused together. So they're binucleated. They have two nucleuses in them. And they have this characteristic kind of owl-shaped appearance, right? It looks like owl eyes. And so if you ever see Reed-Sternberg cells on a test question or in real life on a report, then this is Hodgkin's. This is what makes Hodgkin's Hodgkin's, okay? Now the good thing about Hodgkin's lymphoma is that we can treat this. Most people who have this, we can treat this and they're going to survive. Even if it's advanced. Most of the time we catch it early because the patient's going to come in and be like, hey, I got this big thing growing on my neck. You're going to go, oh shoot, and then you're sending them to probably ENT, they're going to biopsy that thing and then we're going to take care of it. But even if it's later, presents later, they still have a 50% chance of living, so past 5 years. So with non-Hodgkin's, this one's a little bit different, right? So the other one I told you peaks around 25 to 55. This one you're going to see in your older patients, typically over 60 and above. But it still has the same features as far as the lymph node. You're still going to have that painless lymph node enlargement. But the thing about this one is that we have extranodal tumor spread. So I told you the last one, it's going to go from one lymph node to the next to the next. This guy can go anywhere. It can go anywhere where we have those secondary lymphoid organs. So it can go to our spleen, it can go to our airway, it can go to our GI tract, it can go to our skin. And so this one doesn't typically follow that lymph node by lymph node spread. It's going to start metastasizing elsewhere in the body. Systemic symptoms, these are kind of general cancer symptoms, right? Fatigue, malaise, fever. The other one can have that as well, so it doesn't really help you delineate the two. But they're potentially going to present with some type of systemic-like symptoms, weight loss. Now these subtypes, you should know these subtypes because they're easy to kind of pick apart. So we got diffuse large B-cell lymphoma. This is the most aggressive form of this type of lymphoma, of non-Hodgkin's. So these cells, they're rapidly proliferating, right? They're rapidly, they're growing. But because they're doing that, we can treat this easily. We can treat this with radiation, chemo, so it's highly treatable. So even though it's more aggressive, we can actually put these people, if we treat them appropriately, put them into remission. Follicular lymphoma, this one's a lot slower growing. It grows a lot slower. So when it grows slower, it's harder to treat, right? When we try to treat this with chemo radiation, it's not replicating quickly, and so when we try to treat this, we can sometimes buy them time, and oftentimes we do, and sometimes they can go into remission, but if they do, most of the time it comes back. So it's not as easily treatable as the diffuse large B-cell lymphoma. Now, Burkitt's lymphoma, that's a rare one. We don't normally have this in the United States. This is typically seen in Africa, in sub-Saharan Africa, and in children. It's because that there's this variant of Epstein-Barr virus, the virus that we think about when we think about mono. There's this variant that causes lymphoma in the actual child's skeleton, in his bone marrow. And so if you ever, I don't have a picture up here, I should go one next semester, but if you Google this, right, you'll see that because they have these lymphocytes that are trying to grow rapidly in the bone marrow, especially in the face, they get these deformities. So they can have like this just bulging out of their facial bones because those lymphocytes are proliferating in that bone marrow and it's distorting those bones. And so they kind of have this abnormal looking facial appearance because of that. We can treat this easily, but again, this is not something you're typically going to see in the United States. This is more so in Africa. Multiple myeloma, so with this guy here, this is a cancer of our plasma cells. So I told you our plasma cells, they make our antibodies, right? Their lymphocytes transform into these plasma cells, and these plasma cells make the antibodies. But with multiple myeloma, these plasma cells, they go to our bone marrow and they start proliferating. Now what these plasma cells do is that they release these cytokines. Remember, cytokines are these signals to other cells in our body. They signal our osteoclasts, which tell our bones to break down. They stimulate them. They say, hey, we need you to just keep breaking bone down. And then they inhibit the osteoblasts. And the osteoblasts are what help kind of patch our bone, right? What help build our bone. So when we have this stimulation of the osteoclasts and this inhibition of the osteoblasts, we're going to start getting this bone breakdown. So they have this what's called punched out appearance. So this is the x-ray of an elbow, right? If you look, you see all these little black spots in there. It looks like somebody just went in and just punched through it. The stimulation of those osteoclasts and this inhibition of the osteoblasts will cause this characteristic punched out appearance. And when we're destroying our bone, when we're getting rid of it, there's calcium in our bone. So we may have a high blood calcium. That's one of those other neoplastic things I was talking about. When the plasma cells, when they're making, so they make antibodies, right? When these plasma cells start turning into these cancer plasma cells, they're going to start producing this large amount of antibodies. They're going to just keep producing this antibody, keep producing it, and it can actually go into our, it's going to go into our blood, and our blood's going to try to filter that out through our kidney. It can actually cause problems with our kidney to where it starts to damage them. And so when the patient submits a urine sample, they're going to have protein in the urine. It's called proteinuria. Now, you're not going to know what kind of protein it is. You're just going to get this lab report that says elevated protein. Okay, why is that happening? Why is that happening? So typically what you want to do with these guys is you want to take their urine, and you can do electrophoresis with this as well. This is not in there, but this is how you identify that. So you send the urine for electrophoresis, and then that electrophoresis will tell you what types of proteins that this patient is actually urinating out. Let's see. So like I said, you can diagnose this with the x-ray. If you do a bone marrow biopsy, you can see these abnormal plasma cells. But then the other thing you want to do is the serum protein electrophoresis. So you take the patient's serum, and they're making these antibodies, right? They're making these antibodies. And if you send that through the electrophoresis, you're going to see that they're going to have this monoclonal spike. So these globulins, so the immunoglobulins, when you put them on electrophoresis, you have different proteins in your blood, right? Different proteins are going to stop at certain places on the electrophoresis panel. If you get this big spike where normally the globulins are at, typically it should be down here. If you get this big spike, this will kind of key you in that, hey, this is not normal. This is typically associated with multiple myeloma. So that's another way or additional way that you should be testing your patients if you suspect this, by doing this electrophoresis. The thing with this is that when we try to treat this, chemo is not very effective. There are other medications out there, but when we try to treat this with chemo, it's not that effective. And if they don't have these other medications, then they potentially could die within 4 to 7 years. And then the big thing you worry about here, though, is the renal failure, because those proteins start to damage the kidneys, and when they do that, well, then the kidneys aren't functioning anymore. Now you get this buildup of toxins, so you worry about. Actually, the big thing with this is you worry about the kidneys being damaged. All right, so just a summary, just to kind of again help you delineate what's what. Notice Hodgkin's has reached Sternberg cells, non-Hodgkin's does not. Okay, and then multiple myeloma, we're just talking about those proteins or those immunoglobulins, antibodies. But pretty easy to delineate, I think. But all right, platelets. So platelets, so just some key terms. Thrombocytopenia, I think you guys all know this. It just means that you have a low platelet count. Typically, it says less than 150. That's actually normal, I think. Every lab I've been to, if you have less than 150,000, then that's typically thrombocytopenia. If it's greater than 300,000, then we call that thrombocytosis. It means you just have a lot of platelets. And then splenectomy, all that means is that we are removing the spleen. Typically, we're removing it because it's taking out too many of our cells. The same thing here, things that can cause problems with our platelets are very similar to things that can cause problems with anemia. All right, so let me slow down a little bit here. So we got something called immune thrombocytopenic purpura. So let's break down this word just because there's another term in here that looks very similar. So thrombocytopenic, we know that means that decreased platelets, right? Purpura, we talked about this yesterday, where we have this kind of blotchy subsurface bleeding that we can see in our skin. This immune part. So what this means here is that with this disorder, with ITP, we make antibodies to our platelets. The platelets see those, or the spleen see those antibodies, and it starts to remove them from our circulation. There's two different types. We got acute ITP, we have chronic ITP. Acute is normally associated with children, typically after a viral infection. It could be any viral infection. I have some examples here, but any viral infection could potentially kick this off. We have chronic ITP. With chronic ITP, we don't really know what's causing this. It's not typically viruses. Most of the time it actually occurs in women, but again, we don't really understand why some adult women get this. Can it occur in men? Yes, but most of the time it occurs in women. So when you have these autoantibodies that attach to our platelets and then our spleen starts to destroy them and get rid of them, you're going to have procure. You don't have your platelets there anymore. So if you don't have your platelets there anymore, and you have some damage to your vascular system, you don't have that ability to clot anymore because we're taking out our platelets. So they're going to start bleeding under their skin. They may bleed from their nose, so they may have these kind of weird nosebleeds that there's no trauma, or they just kind of brushed against their nose and started bleeding. Splenomegaly, so that spleen is working overtime to get rid of the platelets, and when it starts to work overtime, you're going to get hyperplasia of the spleen. So it'll start growing, not only from trying to get rid of the spleen, but because it has to work so hard, it needs some reinforcement. So it's going to bring in immune cells as well, and the cells themselves of the spleen are going to start growing. So it's going to become big, so you're going to have splenomegaly. Now, with acute ITP, normally, this is going to resolve itself. Typically, within 2 months, it's going to go away. What we normally do is just try to monitor the platelets. As long as they don't dip below a certain point, they're fine. If they start to dip below 20,000, then we'll give them steroids. And what those steroids are going to do is they're going to decrease that production of those antibodies, right? It's going to calm down our immune system. We're going to have a decreased amount of those antibodies, and so hopefully that's enough time for this person's body to kind of get over this, and then they're good to go. With chronic ITP, normally the way we're going to treat this is we're going to treat this with steroids. We want to decrease the amount of antibodies that they're making, so we're going to give them steroids, prednisone, stuff like that. If we treat them with steroids for up to 3 months, and they continue to make these antibodies, then the next best thing we're going to do is we're going to remove the spleen. We're going to take out the spleen, because it's the spleen that's taking these platelets that are covered in antibodies and causing their destruction. So if we take out the spleen, we don't have that problem anymore. Okay? Sometimes with chronic ITP, sometimes we'll get over it, but most of the time, not most of the time, often they're going to continue having this. But if we take the spleen out, the patient is good, we're not destroying the platelets anymore, and so the patient's not going to be having these episodes of bleeding. So here's an example of the spleen. Again, this is normal. This is what it should normally look like. Look how big this guy is. This does not look like a spleen. This looks like something else. So that spleen can get really big, and when it gets really big, we want to remove it because it's doing too much. It's working too hard, and it's causing issues in our body. All right. So the next one is thrombotic. So it's different, right? Thrombotic, thrombocytopenic purpura. So we still have the same thing over here. We have thrombocytopenic, so we have low platelets. Purpura, we still have that bleeding under our skin. But this one, that prefix is thrombotic. So what's happening here is that typically in women over 40, there's some type of infection, some type of viral infection, and our body starts to make these small blood clots. These small little clots within the small vessels, so the arterioles and their capillaries starts making these blood clots. But when our body can counter this viral infection, it made this antibody to an enzyme, and the name of the enzyme doesn't matter, but it made this antibody to an enzyme that normally breaks down von Willebrand factor. Von Willebrand factor is important because it does a number of things, right? We'll talk about here in the next slide. It has to be broken down because von Willebrand factor it's like glue. It helps platelets stick to things. When we take away this enzyme, which is responsible for breaking that down, well, then we're going to have too much of this von Willebrand factor. And when that happens, we're going to start making all these little clots, and we're going to use all of our platelets. So when we use all of our platelets, because we're making all these little clots, we don't have any more platelets anymore, so we're going to start bleeding out. So that's the difference. That this one is making lots of little blood clots. The other one our body's removing these antibodies that are attached to them. This one, we have too many little blood clots. We're using all our platelets, and as a result, we have a decreased amount of platelets, which is going to cause this. The other thing too, when we have these blood clots, is that when they start to clot and our red blood cells start to try to pass through them, they're going to start breaking them down. And when they break down, they're going to cause hemolysis. So we're going to have anemia as well. Now the way we treat this, no, this is dangerous. This one, the other one, it's not good to have, but as long as we treat it, the patient will be fine. This one, we have to treat this pretty quickly, because if we don't, the patient will succumb to this. The way we treat this is we do a plasma exchange, where we take the patient, hook them up to this machine, we draw out their blood, we run it through the centrifuge, kind of like with blood banking, how I told you how they separate the plasma from the red blood cells. That plasma is we're going to separate that, we're going to take away that patient's plasma, and we're going to give them new plasma from a donor, some of that FFP I told you about. When we do that, it's going to do two things. It's going to decrease the amount of antibodies this patient has in their plasma because we just gave them new plasma, right? It's going to give them that enzyme back because our body was attacking the enzyme initially. We take that out, we put it back in with new plasma that has new enzyme and doesn't have the antibodies, and this is how we're going to treat our patients. We can also give them steroids because that's going to reduce the amount of antibody they're making. But again, if we don't treat this quickly, then the patient will die. All right, von Willebrand fracture with this guy. So this is a genetic disorder. Now this thing comes in all types of shades, if you would. There's a severity, and you can have like a minor deficiency, or you can have a major deficiency. But like I told you, von Willebrand fracture, it's the glue. It sticks to whatever's injured, and the platelets stick to this thing, right? So you need that there for the platelets to actually work. When we don't have this, what can happen is that we can have this. Sorry, I lost my place. So what happens is that our platelets can easily bleed, our patients can easily bleed. And so again, it depends on how much they're missing. So if they're missing quite a bit, well then they're going to bleed more. If they just have a minor deficiency, they may be asymptomatic. If they have a severe form of this, then we can actually give them von Willebrand factor. We can give them this factor that's man-made and replace that. So another thing I forgot to mention is that von Willebrand factor is very important in factor VIII. Factor VIII helps is part of the clotting coagulation cascade, and this factor helps prevent that factor VIII from breaking down too quickly. So if we don't have this, then factor VIII is going to break down too quickly, and then we can also have bleeding disorders from that as well. So that's why it's important. Now we don't want to give our patients NSAIDs or blood thinners because if we do, right, those antiplatelet medications are already affecting the platelets. So if they have this issue and then we give them something that's going to stop those platelets from doing their job, then we're going to make this issue a lot worse. So here's that clotting cascade, and again, lab will get into all this with you. There's quite a bit here, but this is just to show you that von Willebrand factor helps the platelets stick more, and it's very important in protecting factor VIII. So if we don't have this factor, well then when factor VIII comes along and tries to do its job, it's going to be broken down too easily, and our patients are going to bleed. All right, hemophilia. So we kind of talked about this, I think yesterday, a couple days ago. So again, it's that recessive disorder. There's different types, A and B. A is definitely more common. Typically, it's less severe. B is that more severe one. It's less common, but it depends on how much of the deficiency you have. Because both of them, depending on how much you're missing of either factor VIII or factor IX, can cause nosebleeds, easy bleeding, bleeding to the joints. And if you have a bleed in the brain, then it can cause cerebral hemorrhage, and that can be very deadly. Now we can treat this with clotting factors. We can give them, again, we're able to make clotting factors like 8 and 9. We can treat this, but just know really that A is more common, typically less severe, and B is less common, but typically more severe. All right, that's it. Questions for me? All right, so I will see you guys. I'll stay up for a little bit. I'll see you guys.